Go ahead, Laura.
Thank you so much, Shannon. Thank you, Zoe, and good morning, everyone. Thank you to the presenters who have already been sharing and those that put information in the Q&A and asked really good questions as well. So as Shannon said, Chris and Kim are with me on this journey that we have for you this morning. And what we thought we would do is really bring to the table some more qualitative information, those profiles of folks. But first, talk a little bit about, hey, what is the process? It's St. Mary's County Detention and Rehabilitation Center for MOUD. We do serve both folks who are coming in already on medication and those who are looking to get on this particular pathway for intervention when they arrive in-house at St. Mary's County Detention and Rehabilitation Center. And a huge shout out to Warden Thompson, who is not able to be here today, but has been so instrumental in terms of leadership to keep this moving forward, as well as Warden Dietrich before her, and even Warden American before her, to really lay the groundwork for what we were able to do once House Bill 116 empowered us to do so, or put the challenge out there. So here's our process at the Detention and Rehabilitation Center that you see on screen. Experts are done by the medical team. Those are not pyramid healthcare folks, but vendors who are through the Detention and Rehabilitation Center separately. But it's all a cobbled together team based on different ways of financing this effort. Once they identify someone, that inmate is referred to Kim, the MOUD counselor. She is one MOUD counselor for all the folks at the Detention and Rehabilitation Center who may wish to get care. In the past 6 months, that's been 85 people who have actually enrolled in care. 115 have been unduplicated through requesting to be screened. So once they are screened, then Kim, along with the help of 2 counselors that are leveraged through what is essentially STOP funding that we have in place at the jail, we get those folks assessed. Our goal is within 24 hours of being identified by medical, and get that ball rolling for them to get them into care. Once they are diagnosed with their OUD diagnosis, they are able to then move through into level 1 outpatient or IOP level 2.1 care inside the facility with our counseling team. Again, Kim is the one MOUD counselor who is there, and then we also leverage our STOP grant counselors to provide some of the 2.1 level care for those who are appropriate for that. And medication, of course, has begun. Our peer specialist, Chris, newly joined us. We just got funding to add a full-time peer specialist to the St. Mary's County Detention and Rehabilitation Center. That actually truly began at the very end of February. And so what Chris is doing is he's meeting with the counselors as they are conducting their groups, as well as individually with clients who would like to pursue more recovery information. Inserted into this process, of course, are those inmates who are able to, with authorization, be pre-screened to go into inpatient treatment. So we are able to also work quickly as possible on that. Once a person gets the green light for treatment, get placed in a bed, and then they begin to work through the process of maybe staying on with us in the Detention and Rehabilitation Center while they're waiting for their bed in counseling, but then get that placement at a range of providers, including Pyramid Healthcare itself and our sites, but also other sites within the available region. Mixed into that, a huge shout out to Sean Dennis, who could not be with us today, and Monica, who are the case management team inside the Detention and Rehabilitation Center itself. Oftentimes, Sean will actually meet alongside of our counselor, Kim, to collaboratively discuss reentry for newly enrolling inmates, and really keeps that ball rolling to help them prepare with the things that they need, right? And that's a two-way street of communication that we're able to have that sometimes concludes when the inmate is released with connection to the local recovery community center, which is also a Pyramid Healthcare program. It's called the Beacon of Hope in our case, and we're really looking for that connection that has been discussed so much already today to be significant in terms of a player for what the experience is for folks in this program. So there are different places along this journey that folks are on that we have looked at in terms of our process. But one of the things I want to highlight is as well what happens when a person gets to go to inpatient treatment. Of course, if it's within our facility, it's much easier for us to do this, but we try to do this regardless. And I believe that one of our STOP-funded community-based care coordinators might be on this learning collaborative. That's Kate. So shout out to Kate if you're still on. And one of the things that happens is that once a person gets into inpatient, we do try to keep in touch. So Kim may be trying to keep in touch and monitor the process, but again, she's one counselor for many, many people. So we also try to have some outreach through either in-person visits, through peer specialists that are a part of our continuum, or through the community-based care coordinators to stay in touch and continue to talk about how is it going? How is the plan for reentry? What do you need as people are moving through inpatient care? They sometimes return back to the jail to finish up sentencing, and sometimes they are leaving from the inpatient facility. So that's very important that we try to stay in touch and help be a part of their reentry plan into the community from there. While inside our facility, our goal is to provide evidence-based practice treatment. We work with a minimum of weekly counseling services. And then, as I said, some folks are able to access IOP services inside the facility. And what we're really thinking about here is trying to provide some recovery foundation and some good groundwork to feel positive about what's going on with this choice to enter into treatment, positive about what's available in the world of recovery. As I think it might have been Larry who might have said earlier, recovery is a lot of work, right? So we recognize that, and you'll see more about that actually in this presentation. In the meantime, if folks are in the facility with the case management components going on, they're able to work toward ID, vital documents. Sean and Monica are also involved in potential placement in recovery housing, looking at benefit eligibility, insurance, the whole 9 yards to get ready to be out in community. And Kim, in the meantime, is as the MOUD counselor, really working on what's that community appointment going to be for that client to get out and get services in the community with counseling and with an MOUD program. And we definitely operate under a provider of choice. But you saw Dr. Weintraub's slide earlier, and you saw where our little peninsula is in a healthcare shortage area. So that is a huge challenge for us to have enough providers to get folks into care rapidly. It was also emphasized earlier how important peer specialists can be. So again, we're so grateful to have Chris with us, who really is tasked with being alongside of folks inside the facility, but also checking on them after, right? Seeing, hey, did you get to those appointments? What were the barriers if you didn't? What do you need? And making that connection with the Recovery Community Center and those community supports that can help with other social determinants of health and recovery capital, as we call it, needs that they might have, support groups, individual coaching, etc. So we've heard about some of this already, but on this journey, we already know about some of the bumpy terrain that we can anticipate for folks that's going to be on their map. Inside the facility itself, lots going on. We've heard from some of the facilities on this call about construction going on, available meeting space, folks getting released early, people kind of coming and going, right? So one of the challenges, of course, is to consistently provide that treatment and peer support while the client is incarcerated, which we believe directly improves their outcomes. But in the meantime, what's the person thinking about? They're thinking about their recovery capital pressures, right? Hey, where am I going to be living? Am I going to be able to find work after release? So these are all preoccupations that are going on, of course, for the client while they are in the facility, trying to get used to recovery, trying to participate in treatment. What we find then is that many folks have not been in recovery before. They may have been in medication, opioid use disorder treatment, or about getting started, but they may not have experienced that long-term recovery where they really see where all this hard work is going to potentially end up for them. So we know we want to educate about what recovery is about and what its potential and promise is. Meanwhile, we have stigma to work through, internal and external, as has been discussed already this morning. Folks that maybe feel stigma about being in the program while they're inside the facility, as well as re-entering into community and trying to continue an MOUD program. A way to stay in touch has also been mentioned. We do work on in our way, providing phones to folks as well. We leverage some funding with a telehealth grant that we were able to be awarded for the county for folks that are continuing or entering into mental health or substance use treatment. We're able to loan a phone and keep up with data as long as they participate in treatment. We also utilize some of our stop dollars for justice involved persons to assist with staying in touch as well if we need to initially. And then, of course, we touched on getting and keeping appointments for care in the community, and all that takes time. It's our time trying to get enough time with the person to get everything done, but it's also the time that the individual needs to have a good understanding of what's needed for recovery, what they might be feeling like are their preferred pathways, trying to discover all those things in the time that we have available to work with them while they're inside, and then trying to stay in touch for that long haul that is recovery once they re-enter community. And with that, I'm going to turn it over to Kim, and she's going to take us through some of our profiles of some of our folks for you.
Morning, everyone. So we'll start off with Marco. Marco was referred both by medical team and self-referred. He was assessed by MOUD counselor and diagnosed with OUD. Marco was placed on MOUD, participated in outpatient treatment while incarcerated, transferred to inpatient treatment, returned to St. Mary's County Detention Center from inpatient treatment to await sentencing and release. MOUD counselor provided referral for the community for MOUD. Aftercare plans were set up at the detention center by reentry case manager to a 3.1 level of care. Follow-up with Marco indicates that he is currently living at home with his wife, who is not in recovery, but has continued with MOUD and substance use treatment, substance disorders treatment, Marco is employed and is in contact with MOUD peer specialists, was referred by our medical team, was also assessed by MOUD counselor and diagnosed with an OUD disorder. Marco was placed on MOUD in level 1 outpatient treatment group within the facility and is an active participant in group sessions. In preparation for court with the possibility of release or home detention, Himeko requested a residential program as he would be temporarily homeless upon reentry to the community due to charges and living in an HUD housing program. MOUD counselor and Himeko made appointments ahead with MOUD provider and local substance use treatment program in advance of court. Reentry case manager and community-based care coordinator reached out to local sober living facilities to set up interviews for enrollment into the program. We were able to offer Himeko funding opportunity from the STOP grant to assist with rent, fees for sober living facility. Our peer support and the community will make a personal accountability contract with him to engage in recovery supports like recovery coaching, mutual aid groups, peer specialists, recovery checkups, while he is receiving grant-funded recovery housing with ongoing follow-up with MOUD peer specialists. Then we have Joan Baptiste. Joan came into the facility on MOUD already and had relapsed prior to incarceration. He was pre-screened for inpatient treatment and accepted into a long-term treatment facility, which he did complete successfully. In community, Joan continued with MOUD and was doing well on probation. Joan's path got very bumpy due to unhealthy relationships in his life that led to a rearrest and incarceration. He has returned to the facility and continues MOUD after a year of maintaining his ongoing recovery through these challenges. MOUD program will continue to support his care, focusing on treatment and recovery paths that help him understand what tripped him up and provide peer follow-up and connections to ongoing care upon release. Aloha was assessed and diagnosed with OUD while incarcerated. She participated in an intensive outpatient group while in the facility. While incarcerated, Aloha also attended individual and mutual aid groups facilitated by peer specialists, member of the local Recovery Community Center team funded by our stock grant. She was discharged upon reentry into community with recommendations to continue MOUD care and substance use treatment. When Aloha did not follow up with community-based appointments to continue treatment, peer specialists who had met with her while she was incarcerated follow up several times and re-engage her with, re-engage including transportation support to and from recovery community centers. Aloha is now enrolled in community-based outpatient treatment, community-based peer specialist team working with MOUD peer specialists and remains in contact. Amelia entered both MOUD treatment and substance use treatment for the first time when she was incarcerated. She was pre-screened for inpatient treatment and accepted into the facility as a detainee. A person in long-term homelessness, she walked out of treatment prior to completion. Her boyfriend convinced her to turn herself in, and she returned to St. Mary's County Detention Center and MOUD treatment care. Upon release, she was offered recovery housing by a reentry case manager and declined because she wanted to live with her boyfriend, who had entered recovery about 2 months prior to her initial incarceration. Community-based programs of peer support, leveraging STOP funding and other local funding have assisted with crisis housing supports while Amelia has remained on MOUD treatment. Amelia eventually obtained her ID, started GED classes, entered workforce on the books for the first time in her life. After 22 months of ongoing recovery and continued MOUD treatment, Amelia and her now husband have at least secured a supportive housing program apartment and will be moving in soon.
So as our heading here says, you know, what we think right now is that in St. Mary's County, our biggest success is access to care. We were recently asked to see how many people since the start of the MOUD program, the House Bill 116 component, that we'd seen. And that was 400 and some people had been through and started on medication. So access is rolling. Getting started on the path is happening. We're converting through the gargantuan efforts really of the one MOUD counselor, Kim, and the help of the STOP team. And now, thank goodness, Chris, to get folks access, to get them started. But the biggest challenge remains helping that client stay on that path. So we have a couple of themes that we figure are really important here to talk about with you. And one of them is client readiness. You know, what stage of change is that person really at in terms of entering the hard work of recovery? Is it contemplative or even pre-contemplative? Probably not pre-contemplative, thank goodness, but contemplative, yes, sometimes. Preparatory, yes, sometimes. And others are really in action. But how well they might be able to do in part when they're released, it does depend on how ready are they for the work of recovery. Do they understand it, right? And on top of that, some of our clients have reported to Chris that, you know what, it takes me 60 to 90 days to adjust to medication. So if they are getting on medication for the first time inside the facility and they're being released during that time frame, or shortly thereafter, the readiness is a real challenge to take on all of this work of reentry and recovery itself. So we're really focusing on helping them with that genuine groundwork of what recovery actually involves. It's long-term, it's ongoing. It requires connection for most folks to some type of recovery program. Research tells us from William White, it doesn't matter really which one, as long as you do something, right? And stay accountable to it. And then, of course, the family needs to have that groundwork as well, with particularly at reentry, preferably before that. Just can't always get to them. So this is a long-term investment, not only for the person, but also what we're finding is for the community itself. And some folks on this call who have presented have also talked about how to follow up in community. And what we're finding is that a lot of our follow-up in community is really about their recovery capital needs. Do they have a safe place to live? Do they have a place to work? What about expungement? How will all of that take place for them? How's their health? What are their basic needs? Do they have food? Are relationships around them supportive or not so much, right? The other issue, of course, that has been mentioned so far already is the DOC transfers. So it's one thing to be working hard with the long-term investment for folks who are re-entering into community, and we at least can try to find them and stay in touch and work with them. But the DOC piece at this current time means that it really does make a question for the client, whether they really want to do the MOUD, what will happen if they have to go to DOC, where at this time it's currently not yet available. And worth mentioning once again is stigma. It's an ongoing issue for the individual. I will say that when I first started working here in the St. Mary's County community, a lot of our local fellowships, particularly where we would hear back from folks that, I don't really feel welcome in some of the programs because people figure if I'm on MOUD, I'm not really in recovery. And I'm very pleased to report that that's been a shift. We have seen differences. There are so many more fellowship groups that are much more welcoming these days in the community. But yet the stigma does still exist even inside the recovery community itself. So just to touch a little bit more in detail about what we have referenced, which is that we have a very small team for MOUD that's funded inside the Detention and Rehabilitation Center. So we have absolutely had to leverage a lot of other resources to make things happen, both inside the facility to support the efforts that Kim and Chris have underway, as well as at reentry. So some of the things I'll highlight that we do utilize are, we're very fortunate that the St. Mary's County Detention and Rehabilitation Center has received a STOP grant, and we are able to administer that programming on their behalf. And so we are able to utilize that funding to really help us stay in supportive relationships. So sometimes it is the difference that we can have a peer specialist inside working specifically with the women to provide support groups in the jail, to assist Chris, who's working with all 85 people that might have come through in the last 6 months, as well as out into the inpatient communities, treatment programs, and our care-based coordinators being able to visit with them out there, our peer specialists doing outreach out there, and then able to help them with some of those recovery capital needs. We have spent quite a bit of funding on Ubers because of transportation issues on our peninsula to get folks where they need to go. The telecommunication piece I've mentioned, we're also able to utilize those funds to provide some scholarships to recovery housing because one of the top questions is how will a person who's re-entering pay for a recovery house rent. So we've been able to invest in that, vocational needs, food on the table, clothing is a big piece. When people are re-entering or when they're leaving the facility, the Detention and Rehabilitation Center, and they're going to inpatient treatment, they often do not have either any clothes or they got arrested in the summer and it's February, right? And they don't have anything to wear. So we've been able to leverage those grant funds to get them some decent, appropriate clothing for the dignity of that human being, as well as what it's going to be needful for their basic concerns. Another leveraging point that we have is that we are the holders of adult recovery support funding for St. Mary's County. So we do provide the Recovery Community Center, the Beacon of Hope ourselves. And so that entire team is able to be in communication with Chris, the MOUD peer specialist, as well as with Kim as needed and the community-based care coordinators to really invite them in, invite these folks into what is the recovery home that we hope they'll have. Challenges there are, according to a recent group that Chris conducted when he talked about the Beacon of Hope, just about 10% of our folks in that meeting actually said, I know what that is. 90%, right, did not know. And this is the Recovery Foundation Challenge that we've been talking about. We're also fortunate in the community to have wraparound problem-solving court efforts underway. We do have an adult recovery court. There are diversion programs in pretrial and home detention that the sheriff's office runs. And that's all part of the picture sometimes for folks to increase their accountability and access to knowing about resources where care coordinators and others can reach out to them. So I do want to just mention one thing. I've talked about Chris a couple of times. You haven't heard him speak. He's recovering from an illness, so he'll speak as much as his throat probably will allow him to speak moving forward. So one of the things that and I think our whole team really wanted to emphasize when we were asked to present was, hey, we don't have all this figured out. We are definitely a work in progress. We're proud of what we have accomplished, of course, but we know there is a lot to still work on. So we wanted to share with you some of the things that are most on our minds at this particular time. And so certainly, as I think several presenters talked about, it's really important to begin talking about, hey, where are you headed as soon as possible? With a high volume of patients, of clients, it is very challenging, but to anticipate what releases of information we're going to need so we can get that post-reentry follow-up flowing is definitely something that Kim has named as an important goal for the program. And I really appreciate that insight. We really do want to be able to stay in touch and double check, right? We want to get our referrals for the community-based treatment plan in place as early as possible because early release, as I said, does happen frequently. Trauma, grief. Kim has mentioned that when providing treatment, these are two themes that are coming up for people quite often, and what resources we have down on our peninsula to assist with that. Right now, it doesn't seem like we have much capacity, so it would be very nice to try to work on finding trauma specialists to work with our folks, grief counseling to work with our folks. Our Beacon of Hope Recovery Community Center has a mutual aid group for grief recovery, but that is not, of course, the same thing as having a professional therapist to work with. So we're also working very much on really leveraging the power of the Recovery Community Center to help folks get their recovery home cemented and find out what their interests, their preferences, and their choices might be if they had the opportunity to continue to explore them. But people kind of fall off the touch, right? So we are very much trying to figure out how to really achieve a very solid record of warm handoff between folks leaving the detention and rehabilitation center or leaving their inpatient treatment center where they may have gone from the detention and rehabilitation center into community. We do not have a vehicle. We can get an Uber for folks, but that takes a little bit of coordination. And if they're just wanting to go see their family first and they're like, yep, I'll see you later, I'll be in touch, we don't always get that, right? So as was said, the phones, the transportation to show up at the center, if we can get them there, our chances of being able to stay in touch with them are much higher. That also means we need to make sure that they're very aware of these programs, as well as their treatment options for reentry. So we're going to be working on trying to do a better job internally within the facility of the Detention and Rehabilitation Center in terms of marketing recovery resources, as well as those treatment resources that are out there for them. talked about leveraging the telehealth grant to try to help people stay in touch. And also that it stands out, Dr. Weintraub had shown a slide earlier on in his presentation in the 9 o'clock hour of attitudes about MOUD, understanding about MOUD within different positions and disciplines across this continuum that we're working in correctional facilities. And we really are aware that not only does our client need a little bit more support about the education of the power of MOUD for them, but also we don't want to forget in our busyness that folks have questions. We have oftentimes new people, new to corrections, who are coming in and working in our facility. And I know Warden Thompson has said, it'd be great if we could figure out how to create space and time to do some education within the facility for those folks that are so integral and so much appreciated, that are making sure that the security and safety of the facility is happening, as well as also our medical team partners. So we're all one big team, and we all have understandably questions of each other, and we want to really work on communication.
I was really struck by particularly in the vignettes, the case examples that were provided, the critical issue of housing instability in terms of being able to make plans as a barrier. Like, what are your plans in the community? You can give me all the referrals you want, but if I don't know where I'm living, or if I can even stay locally, it's hard to make those kinds of plans. And you mentioned several ways in which the treatment process, like who you link them with, can help with that, like if it's inpatient or residential or some sort of recovery housing. And I wonder if you mentioned, particularly Laura, the issue of recovery capital, and how early you start the conversations about your plans and what are you expecting in the community. And in addition to phones and transportation, housing is really big. I wonder if you could speak to the way that you've been gathering resources that are suitable for the folks as they're leaving your detention facility to meet all those really critical needs.
Yes, Shannon, you're absolutely right. That is huge. We are required when we're utilizing grant funding for recovery housing support to make sure that program is MCOR certified or has a special relationship with our local behavioral health authority. And so we find ourselves in St. Mary's County utilizing primarily recovery housing in the county and in Calvert County. There is one certified housing recovery house there as well. Oxford houses have been huge. They've been, thank goodness, really opening houses every couple of months in the last year or two here in our Southern Maryland community, and that's been a huge support. They are really always at the other end of the phone for Sean Dennis with the St. Mary's County Sheriff's Office, or for us in our recovery support programming efforts to try to get people placed if they have a bed. We are really able to rely on their partnership. Other areas that we are able to explore for folks are 3-1 programs at times, or even housing and longer term care programs in other parts of the state. We did just get to open our company, Pyramid Healthcare, just reopened a 3-1 program. It is for men only in St. Mary's County. So we also do now have that resource within the community for some folks. But part of that ability to go elsewhere for that type of placement means that we have a transportation coordination piece where, again, we leverage some of the STOP grant funding to assist folks who may have court back here in St. Mary's, but they're in Frederick, they're in Hagerstown. So they're staying in touch with the peer specialists when they're going to need to get back for court. And thank goodness some Uber drivers are willing to take the day, really. and help us handle this, because we do not have vehicles to just disperse to them and go pick them up. So yes, we can rely on recovery housing that we couple together, including out of the area. But many people also have to be reassured they're going to be able to get back to meet their commitments back in this area.
That's such an important point. Yeah, just because your recovery has sort of moved to a different county, your obligations in St. Mary's County don't necessarily go away. And you solve one problem by housing, but then you create other kinds of considerations, like even increased transportation challenges to get them to those mandatory appointments.
Right. And you know, the telemedicine piece has been discussed in today's Learning Collaborative, but also the telerecovery piece bears mentioning that we can do a lot through the lending of phones, particularly smartphones is what we focus on, because we want them to be able to not only be able to be involved in telemedicine, telehealth, but also to be able to utilize Zoom and other apps so that they can actually attend recovery support meetings. The range of, thanks to the pandemic, the range of recovery meetings that folks can attend, from 12-step fellowships to smart recovery, you name it, has increased exponentially, really, where someone can be in a meeting with someone from Australia, someone from Iowa, and someone from Maryland, you know, and who knows where else, all at once. And you really do get to see how recovery is done so many places. But that's important to keep in mind, is to connect people with those ongoing resources. And that does mean, again, data and devices.
Okay, we can see you.
Hi, hello, everybody. I don't have a question, but so I'm Darren McGregor from the Behavioral Health Administration, and I really just wanted to give a special shout out to St. Mary's. They have entered all these uncharted waters many years ago, working with Warden Thompson and working with the local Behavioral Health Authority, Tammy Lowy, and all the provider groups. They really are to be commended when we need to know something about what does it look like at the ground level. They have been extremely responsive, and a meeting like this, I know they worked closely with the Friends Research Institute, the OOCC, BHA. So no comments or questions, but just a big thank you. You've really been a friend to us, and hopefully we've been a friend to you.
I was wondering, because, and not that there's any pressure on Chris, but he's a new member of your team, and I was wondering how the thinking about reentry or coordinating that process has changed since you've had that dedicated peer in that role.
If you're getting your reentry case done early on, when you first get there, maybe 60 days prior to me even meeting with you, or you even being in your first IOP or OP class, or whatever the case may be, it's giving you a lot of time to kind of decompress with the stress when you first came in, deal with coming off of whatever drugs you were using, coming on to whatever drugs you're coming on to. So I see that a lot of people's minds change. And then that frustrates the reentry manager, right? Because he's like, well, a week ago, you told me this or that. So the windows are very small for change. And the sense of urgency that we have to have has to be high, but then the patience has to be even greater, because then the person might change their mind again in 2 more days. So I think the patience level of reentry is important. And then if you look at the case of Amelia, her journey of 22 months, and that's almost 2 years, right, of doing the right thing and still living in a very poor situation, is realistic. And I guess my question for the group or for whoever is, what kind of long-term plans or long-term recovery, what does that look like going forward, and what does that look like now? Because for her, and that's just one person, but I can think of many more that really struggle with, they go back and do the things they were doing before because of the pressures that life demands, right? They want to make up time with their kids, but then they can't get a job. So now they can't go buy their kids a toy or provide for their family or do whatever they want to do in that sense. But yes, do work with males and females. So real quick about the males and females, the huge difference. The females, I've worked with way less females and been able to help them get to the beacon of hope quickly, because there's not as much pride and ego built up as in the male side, where the pride and ego of just being in jail is far greater than the women. So the amount of patience that it takes to break down those walls and barriers for people to actually want to work on themselves and admit that they have something going on is way greater than on the female side of things too.
Yeah, thank you. Laura, you said you leverage your STOP grant to bring in female peer specialists. That's right. I remember that discussion. Yeah, that's certainly a consideration in terms of gender issues as well. Absolutely. Was there something else you want to add?
I was just gonna say it can be, but Chris is such a person that it really, I hear from the counselor who primarily works with women that it's not an issue to talk with Chris. So it's good to have Audrey is her name, be able to come in and work women with that. But I do want to give a shout out to Chris that he has a demeanor that is such that it works with both
That's wonderful.
the ladies and the gentlemen.
Yeah. Looks like we have time for one more question. I see Stephanie's hand raised.
Yes, hello. I am the reentry coordinator at the Allegheny County Detention Center, and I work very closely with Angel Delverne. And we have 2 peers that come in from the community that are funded by grant money, and we have both a male and a female. And that's why I asked, because our policies around here are kind of keep the females with females, males with males. So I was just curious and to see how that worked out. And it's funny you say about the women being easier to convince. I find that as well. I set up a lot of inpatient treatment for when they finish here at the detention center, and the number of women I send is probably double to the number of men I send. So very interesting.
Yeah, that's, and when you consider what a smaller proportion of women are probably coming through your facility as well, that's, I think, even more pronounced.